All right, let's talk about ATN, acute tubular necrosis. Most common cause of kidney injury in hospitalized patients, spontaneous resolves in many cases, can be fatal, especially during initial oliguric phase. Increase in FeNO, fractional excretion of sodium, and we did talk about it already being a intrinsic kidney problem in the AKI. So now they're defining it more, acute tubular necrosis. So you have the key findings here. What are the key findings? You have the granular cast, very important, often muddy brown in appearance. So which kind of cast you can see in ATN? Muddy brown. Why muddy brown? Because in acute tubular necrosis, the name suggests it, tubules are going into necrosis. So their epithelial or endothelial cells are going to be sloughing off because of necrosis, and they are going to form, those epithelial cells are going to form muddy brown cast when they come out, right? There are three stages. One is the inciting event. Then you have the maintenance phase, in which you have the oliguria, which lasts 1 to 3 weeks. There is a risk of hyperkalemia, metabolic acidosis, uremia. But again, you have the recovery phase, in which you have polyuric and the creatinine fall, risk of hypokalemia and renal wasting of other electrolytes and minerals can be seen in the recovery phase. It can be caused by either ischemia to the kidney or nephrotoxic injury. So what are the nephrotoxic and how the ischemia occurs? Let's look at that. Ischemia occurs secondary to decrease in renal blood flow because of the prerenal azotemia. You decrease the blood flow, you cause prerenal azotemia. That decreased blood flow caused the death of the tubular cells. Now those will slough off into the lumen. PT, the proximal tubule, and the thick ascending limb are highly susceptible to injury. Very important. PT and the thick ascending limb are highly susceptible to injury because of that low blood flow. Okay. But the second thing is the nephrotoxin. What nephrotoxin we're looking for? That is the secondary to injury resulting from toxic substances like aminoglycosides. Very important. Radiocontrast agents, lead, cisplatin, ethylene glycol, myoglobin, urea. That comes from the rhabdomyolysis or hemoglobin urea. PT is a particularly, now they're telling the proximal tubules are particularly susceptible to injury for the nephrotoxic. So if you have any toxin, that is particularly going to damage your PT. But if you have ischemia, that is going to cause PT damage, which is the proximal tubule, but it can also cause thick ascending limb. But PT is again, you keep PT in mind. That's way important. So that's pretty much what we have for the ATN.